Human hair follicles exist in two primary states: fine, unpigmented vellus hairs and thick, pigmented terminal hairs. But when exposed to specific endocrine signals, a vellus follicle transforms, anchoring deeper and thickening into a terminal hair. This diagnostic slide presents the medical definition of hirsutism. It denotes the excessive growth of terminal hair in androgen-dependent areas of a woman's body. Common sites mapped here include the face, chest, abdomen, the back, and the thighs. We must distinguish this from hypertrichosis. Hypertrichosis produces a generalized increase in hair density anywhere on the body, independent of circulating sex hormones. Hirsutism is an androgen-driven process, resulting from an excess of hormones or an increased follicular sensitivity to them. Looking at the epidemiology data on this slide, we see the scope of the issue. Hirsutism affects approximately 5 to 10. This table of investigations details the biochemical markers used to trace the hormonal source. Clinicians measure serum total and free testosterone, DHEAS levels to evaluate adrenal output, the LH to FSH ratio for suspected PCOS, and 17-hydroxyprogesterone to check for specific enzyme deficiencies. The results of those assays form the basis of the differential diagnosis seen here. They allow the physician to separate a benign hypertrichosis, or classic PCOS, from a late-onset CAH or a severe adrenal tumor. Pinpointing the exact anatomical source of the androgen overproduction, whether it is the ovaries, the adrenal glands, or the local follicle itself, determines which pharmacological intervention will effectively disrupt the mechanism. This slide breaks down the core pathophysiology into distinct steps. The clinical presentation requires increased systemic androgen production, enhanced peripheral conversion to dihydrotestosterone, or DHT, and increased sensitivity at the target hair follicle itself. To understand how drugs intercept this process, we have to map the biochemical pathway. It begins systemically, with the ovaries and adrenal glands synthesizing and releasing baseline levels of circulating testosterone. In the bloodstream, a specialized transport protein called sex hormone binding globulin, or SHBG, regulates availability. SHBG binds to the majority of this circulating testosterone, keeping it inactive. Only the unbound fraction, known as free testosterone, is biologically active. That free testosterone exits the vascular system and diffuses directly into the local cellular environment of the hair follicle. Inside the follicle, an enzyme called 5-alpha reductase processes the free testosterone, converting it into a much more potent molecule, dihydrotestosterone, or DHT. Pacing tightens. When DHT locks into the androgen receptor inside the cell, it flips the biological switch. This is the exact mechanical trigger that forces a fine vellus hair to transform into a coarse terminal hair. Medical treatment relies on chemically interrupting this sequence. We can cut off production at the systemic source, block the conversion enzyme, or shield the receptor itself. As outlined in this management summary, the first-line therapy for most women combines lifestyle modification with combined oral contraceptive pills, or COCPs. COCPs execute a two-pronged attack on the androgen axis. First, the synthetic estrogen and progestin in the pill suppress luteinizing hormone secretion from the pituitary gland. This effectively shuts down the excess androgen production at the ovarian source. Second, the estrogen component stimulates the liver to produce more sex hormone binding globulin. This extra SHBG acts like a sponge in the bloodstream, capturing and deactivating the remaining free testosterone before it can reach the skin. For patients whose hirsutism is driven by PCOS, there is often an underlying component of insulin resistance driving the hormonal imbalance. In these specific cases, metformin is frequently utilized. Metformin improves cellular insulin sensitivity, which lowers overall circulating insulin levels. Because hyperinsulinemia directly stimulates the ovaries to produce androgens, lowering insulin subsequently reduces the excess hormone output. While systemic suppression is highly effective at reducing the circulating volume of hormones, severe or established cases often require a secondary line of defense directly at the skin level. When systemic suppression fails to fully halt the hair growth, clinicians introduce targeted anti-androgen medications to establish a local chemical blockade. Returning to our management chart, we see spironolactone and finasteride listed as the primary anti-androgen interventions for these resistant cases. Spironolactone is the most commonly prescribed medication in this class. It works directly inside the hair follicle. The drug physically occupies the androgen receptors, creating a barrier that prevents any circulating DHT from binding and triggering growth. A related drug, flutonamide, acts as a pure receptor blocker and is highly effective in severe presentations. However, it requires strict liver function monitoring due to a known risk of hepatotoxicity, making it a rare choice in modern practice. Alternatively, we can target the local conversion process itself. Finasteride operates by mechanically jamming the active site of the processing enzyme. Specifically, finasteride acts as a 5-alpha reductase inhibitor. By disabling this enzyme, it prevents the local tissue from converting regular testosterone into the highly active DHT molecule, effectively starving the follicle of its primary growth signal. These peripheral intercepts ensure that even if the systemic hormone levels remain slightly elevated, the localized hair follicles become chemically deaf to their signals. This complications and prognosis slide highlights a critical clinical reality. While long-term therapy yields good responses, patients must be informed that visible clinical improvement typically takes a minimum of 6 to 12 months to manifest. This delay reflects the inherent timeline of human biology. Hair follicles operate on distinct asynchronous phases of anagen growth, catagen transition, and telogen rest. Systemic drugs and anti-androgens are strictly preventative. They stop vellus hairs from converting into new terminal hairs, but they cannot eliminate the thick terminal hairs that have already been established. Because the pharmacological process is slow, patients require immediate cosmetic interventions to manage the existing symptoms while the drugs take effect. To accelerate localized results, clinicians prescribe topical therapies like eflornithine. Applied directly to the skin, this cream inhibits an enzyme necessary for hair follicle rate of new facial hair development. During the year-long onset phase of the medical therapies, physical cosmetic methods such as shaving, waxing, or laser hair removal serve as the necessary bridge to maintain quality of life. However, the addition of localized anti-androgens carries a severe clinical warning. These drugs are highly teratogenic. If a patient becomes pregnant while taking an androgen-blocking medication, the drug will actively interfere with the development of male fetal genitalia, causing severe feminization. For this reason, the concurrent use of highly effective contraception, such as COCPs, is absolutely mandatory when prescribing anti-androgens. As the final conclusion slide establishes, hirsutism is an outward marker of internal androgen excess. Favorable clinical outcomes depend entirely on early diagnosis, targeted pharmacological intercepts, and a rigorous multidisciplinary